I want to thank you for joining us. I'm Dr. Dennis Kim with the AAST Communications Committee and the Quickshot Subcommittee. I am joined today by Dr. Mohammed Zeeshan, who is currently a resident at Westchester Medical Center in New York. Thank you so much for joining us, Mohammed.
Thank you so much, Dr. Kim. And I just wanted to thank the AAST program committee for this opportunity and highlighting my quick shot. I'm really excited. I was looking forward for this interview. And thank you so much, Dr. Kim, for giving me time to discuss my paper as well.
Yeah, so Mohammed, is this your first time presenting at the AAST annual meeting?
So it is actually my third time presenting at AAST meeting.
Fantastic.
Research at University of Arizona with Dr. Bilal Joseph, and I presented a couple of papers over the last 2 years at AAST.
Wonderful, wonderful. And tell us a little bit about your study. So we're looking at an elderly trauma population and looking at predictors of survival following craniotomy. How did this idea come about? And tell us a little bit about the objectives of your paper.
So during my trauma rotation, I was seeing there were a lot of patients who were coming after a fall and who are severe TBI in this population. And I think most of our trauma, maybe around 50 to 60% of the patients were geriatric patients. And they were who had multiple comorbidities, including frailty. They were on anticoagulation, antiplatelets. And many of them just come with a simple fall and they have a very severe TBI. Then we have this dilemma, like because of their severe TBI and their increase in intracranial pressure, should we do a surgical management in terms of neurosurgery, maybe craniotomy to decrease the pressure in the brain? So we were dealing with this dilemma. Like we used to have these long discussions, like how can we identify a specific subset of population in which we can do this procedure and we can safely manage these patients, because many of these patients when they do undergo anesthesia, they are at increased risk of multiple complications, including prolonged ICU length of stay, delirium, they get infection, they are on ventilators for a long time. So we just wanted to have like an idea, or I just wanted to take a look at the data, like what are the indicators or what could be the specific factors which can tell us like this is a specific subset of geriatric TBI patients which might benefit from craniotomy.
Yeah, I think that's a really important question, especially when we're having discussions with loved ones and family members as to whether or not we should be pursuing aggressive surgical intervention. And so having some idea as to what preoperative or perioperative risk factors might predispose towards an untoward outcome might be helpful to have in that conversation.
Exactly. So I agree with you. Because of this paper, we will have like a specific objective data, like with which we can talk to the family and we can have a discussion about the procedure and we can answer their questions in a very comfortable way without just giving them random numbers. So that's why I just want to take a look at different factors affecting the survival or mortality in these patients.
Great. And can you explain to us a little bit about the methodology and what was your primary outcome measure?
So we did a 2-year analysis of American College of Surgeons trauma quality improvement database, which is one of the biggest trauma databases, I think, in the whole world. And this database includes data from around 800 trauma centers around the US, and it is managed by different coders and decoders, and there are specific program coordinators for this trauma database at every trauma institute. And American College of Surgeons have definitely did a really great job managing this database. So I just wanted to I did a 2-year analysis of the TQIP database, and I included all the geriatric patients, geriatric being the patients above the age of 65, who had an isolated TBI, which means had AIS of greater than 3 and the other body injuries, AIS less than 3. And I included all the patients who underwent craniotomy I excluded the patients who died within the 24 hours because there many of the people would argue like they had unsurvivable TBI. So I also excluded the patients who were transferred from other hospitals. And I just did a simple univariate analysis. I compared like patients who survived and who did not survive. And then I did multivariate regression analysis to look for the factors which were affecting the mortality. So the primary outcome for my study was mortality because I was just focusing on mortality. And I think this is one of the biggest questions in these kind of patients, like if they will survive the surgery or not. So my primary outcome was mortality.
Great. And that was in hospital mortality.
It was in hospital mortality.
I mean, one of the things that does come up when it comes to elderly trauma is the issue of DNRs or aggressiveness of care, as well as withdrawal or that transition from life-saving interventions towards comfort care. I guess when you're using a database like TQIP, you probably don't have that data in terms of how many patients were actually transitioned to more comfort care route post-operatively.
Yes, Dr. Kim, like with TQIP database, I have this limitation that we could not take a look at DNR or DNI status or if there was a withdrawal of care after family discussion. So I do not have the data regarding that.
Yeah. And Dr. Zeeshan, what were the major findings, or were there any findings that surprised you and your group?
So the major findings were there were different factors which were associated with these with poor outcomes in these patients. For example, the age of 85 or above, the use of antiplatelets or anticoagulation before the injury, and concomitant two or more than two intracranial hemorrhages. And if the patient was frail, all these factors were associated with increased mortality in these geriatric patients.
Yeah. And so based on the results of the current studies, any future plans or plans for further research along these lines?
So I am working with our senior authors, Dr. Peter Ree and Dr. Rifat Latifi, and I want to take a look at the database from our institute. And the main theme was to get an idea of, to use the TQIP database to get an idea of the different factors which are associated with the poor outcomes in the patients with the geriatric patient undergo craniotomy. The next step would be to look at our own database, and I want to take a look at the specific size of the intracranial bleeds, and I want to create a score, we can create a score in which like we can put simple factors and it can give us this will be the mortality of this patient, and we can define the category of the geriatric patients who would benefit from craniotomy using a score. So the next step would be to analyze the data from our institute, and we would like to create a score through which we can give different categories to these geriatric patients, and then we can go from there.
Oh, very interesting. It's, as I'm looking at myself during this interview, it looks like I've actually had a craniotomy using this virtual background. I guess the other thing that would be interesting as well is as you move forward, looking at the more long-term outcomes, where do these patients end up? And then what's their actual functional status 3, 6, 12 months out from surgery, which might be more doable if you're doing something at your own shop versus using TQIP.
Yeah, so that is the plan. Like I want to do one study, like in a retrospective manner to create a score, and at the same time we will do a prospective study to look at the long-term outcomes in terms of their cognitive abilities and the functional status when they go out of the hospital.
That's wonderful. One last question, Dr. Zeeshan. Why did you end up submitting to the AAST? It sounds like you've had a few presentations, but what is it about the AAST that attracts you as well as your research co-investigators to submit your scientific work here?
So I think AAST is, I believe it is one of the elitist trauma conference. And being a surgery resident, I'm aspired to go into acute care surgery, and I want to train as a trauma surgeon. So that was the main, I think, the drive to submit to AAST. Other than that, like, I love to attend AAST and present and discuss, and there is a lot of science going on AAST. And the other thing was this year AAST was supposed to be in Hawaii, so that was the reason too.
Yeah, always one of the more competitive years. And obviously, you have some fantastic research mentors to help guide you through this process. And I agree with everything that you just said about the organization. And again, congratulations to the program committee. I mean, this meeting has gone off really without a hitch and has been a really fantastic virtual meeting to attend. Any final comments, Dr. Zeeshan?
Well, I just want to say thank you. Thank you for your time. And I would just want to thank the program committee for this privilege of presenting my paper. And I have my mentor, Dr. Prabhakaran, who's a trauma director at Westchester Medical Center, Dr. Petery, who's the chief of trauma at Westchester Medical Center, and Dr. Rifal Tifi, who is the chair of surgery at Westchester Medical Center. I just want to thank them for giving me this opportunity and just pushing me to do more and more research and involve in academics.
Well, congratulations, Dr. Zeeshan. Fantastic job. I'm really looking forward to watching your presentation next week. And thanks once again for joining us for this interview.
Thank you so much, Dr.